We're here at the conference in Vancouver, BC, and we're here with Doug Dietrich, who's from Mount Sinai Hospital in New York. And you are always gracious enough to spend a little bit of time with us to talk about what is new in the field of HCV, which has been enormously busy over the last few years.
It's been huge.
Without saying. But there is a little bit of things happening. You say more new good news. Tell us about that.
Well, we've got several drugs already approved, which we've been using quite liberally in our co-infected patients. The Gilead combination of sofosbuvir and ledipasvir, otherwise known as Harvoni, and the AbbVie combo of ombidisvir, paritaprevir, ritonavir, and dasabavir, both of which have very good studies supporting their use in HIV and good results, meaning actually the same SVR rates, the same cure rates as in mono-infected patients. So we're actually been using those since late last year, November, December of last year, with great success. So the cures are now rolling in from the use of those. In a couple of weeks, August 15th, we expect decladisvir to be approved from BMS, which will actually help us with our weak point, which is genotype 3. And that's a problem, actually particularly in our cirrhotic patients. So the combination of decladisvir, sofosbuvir, with or without ribavirin for genotype 3 will be very welcome, actually, and we'll be able to start using that probably right after Labor Day.
Are there genotypes that are not, or patients who are not being, going to fruition with the treatments, or realizing they can't, be cured?
Very few. When I sit around the table with my colleagues, and we've all treated hundreds, literally hundreds, most people have had between 0 and 5, count them on one hand, relapses. And usually they're patients who have cirrhosis or lymphoma, or they're difficult to treat.
Were they discontinuations, or they realized it didn't work?
No, typically they're relapses. All these drugs are so potent they relapse. So I think it's probably, and I think we saw that illustrated at EASL really well, because we have both the Merck and the Gilead triple therapy with super drug studies trying to go down to 4 weeks and 6 weeks, and neither of which worked. So the drugs can't get much better than that. So it's not a drug issue. The drugs are fantastic antivirals. It's a host issue. So most people will take longer than 4 weeks to clear the virus. I think that's the issue. We also found out at EASL that 8 weeks in HIV patients with the Ally 2 study, decladisvir and sofosbuvir, was not sufficient. It was definitely inferior to 12 weeks. So it does look like there may be a hint that HIV is a little bit special in terms of needing slightly longer treatment, but not, pretty much the standard, 12 weeks. But other than that, it's not a special population anymore, except for the drug-drug interactions.
So you're really learning how best to treat with all populations. Do you know in advance who will be better, better able to clear the virus?
Well, sure. We always know the negative risk factors. In the past, the poor prognostic factors. Most of those don't matter anymore. But I think in one study we saw that if you have 3 or 4 of 5 poor prognostic factors, they can add up and
It's synergistic, or
give you
just
trouble.
additive, or?
Yeah, they're additive. And the other thing is, of course, we know that cirrhotics are always more difficult to cure than non-cirrhotics. So we'll typically go 24 weeks for patients with cirrhosis, or we'll add ribavirin where we wouldn't ordinarily do that. And most of the guidelines reflect that as well.
So with the very few people that you can actually count on, each doctor on one hand, what do they do? Is there anything that can be helpful?
Sure.
Are there drugs coming down the pipe that may?
Yeah, it's actually not even coming down the pike. We have Plan B, we have Plan C, we have Plan D. There's lots of things coming. For people who fail the sofosbuvir, ledipasvir, we've been talking about using, because then they all fail with NS5A resistance. So we've been talking about and there's a paper already actually presented in Europe about it using Simsoft, Imipravir, sofosbuvir, because there's no NS5A in the combination, and that it was 15 patients, but the SVR rate was over 90%. That's one possibility. You could also use the AbbVie combination, for instance, in those people. The sofosbuvir or ledipasvir failures, even though they have NS5A resistance, I think if you add ribavirin, most of us think it would probably work, you know, in those patients. The patients who fail the AbbVie regimen, it's a little more difficult because they fail with triple drug resistance. So then we might have to wait for Plan C, which are new drugs that are coming down the line.
But it seems very, very promising. So with great news and then even more good news. So
it's mind-boggling.
Yeah, you will be giving a presentation. Is there anything that you can? We won't be talking about this until after that. So obviously, it's all embargoed.
Honestly, there's really nothing. There's no shockingly new news here. It's like I think the basic take-home points is the cure rates in HIV patients treated for Hep C with the new DAAs are exactly the same as those who don't have HIV.
Great. Well, this has been always good news. I mean, recently anyway. It was a long haul to get here, but actually, in terms of science, it was a rather quick movement from where we were until where we are today.
It's really only been since 2011, April of 2011, where we saw the first proof of principle that you could cure Hep C without interferon or ribavirin.
But there's been a lot of industry push and government push, and I think, and now we have to make sure that everybody, now quickly talk to the issue of the money, because it's obviously been grandstanded. Wow, this is a lot of money to pay, a $1,000 bill. So, but there is the rebates and address.
Yeah, there's all sorts of stuff that's going on and negotiating in the background that's all private and no one knows about, but there's rebates, there's discounts, there's government discounts that are mandatory. And there's also generics that are being manufactured in India and Egypt. Although I wouldn't recommend anyone going there to get the generics, because there's a huge counterfeit, drug problem.
I imagine with the price that would be an automatic assumption. But with that, you have a lot of good. The pricing, and then of course the patient assistance programs.
Yes, both AbbVie and Gilead have been very generous with patient assistance, and frankly, it's unbelievably cost effective to treat this disease. I mean, it's such a no-brainer from an economics perspective. Medicare has been very generous because they understand nobody is going to leave Medicare for 25 years if they make it to 65, basically. So. The return on investment is 4 or 5 years. It's just the commercial insurers are not willing to do that, even though the per patient per month and per patient per year healthcare costs for patients who are cured of Hep C drop by 300% as soon as they're cured. I mean, it's really remarkable.
That's amazing.
It just takes a little while. It's a more expensive drug, so the return on investment takes a little longer, which the commercial guys don't have a long-term time horizon. The VA and Medicare do.
When if they factor that into the cost of the initial price of the drugs and so forth, that there's a benefit still with the high price?
Oh yeah, there's a huge. I mean, it's one of the it's almost the most cost-effective thing on the in the medical armamentarium, second only to screening for colon cancer.
Wow, that's amazing. Well, I really appreciate you taking the time, and good luck with your presentation and your
Thanks,
your
Fred.
whole symposium there. And I know there's nothing shocking coming out, but the news is great.
Yes,
it's
all
just
good
wonderful
news.
to hear this.
It's all good news.
Thank you so much, Doug. Appreciate it.
Pleasure, Fred.